with WeSpark since the very beginning. I was there before the doors opened and was really one of the first nurse navigators. And my background is I was an oncology nurse at Cedars-Sinai for 10 years. And then I worked home hospice for a number of years. And then I was at WeSpark as doing intakes and doing some of the nurse shell answer person. And what we're going to be talking about a little bit today is advanced directives and choices, making choices. It's something that we're all asked to do from time to time. Whenever you go to the doctor, they'll ask you, have you made your advanced directives? Or you might be dealing with a family member who has made them. And so I give you all a lot of credit for being here and talking about that elephant in the room that, I always go back sometimes because for years I ran the metastatic cancer support group, and the patients would often tell me that they wanted to talk about death and dying. They wanted to understand it and know more about it. But the two groups of people who were always reluctant to discuss death and dying were their doctors and their family. And we're trying to make a shift in that now. We want everybody to be talking about it a little bit more, because you won't hear anybody saying 1 in 5 people who are infected with COVID were dying, often without anyone at the hospital with them. And we hadn't really had a lot of these discussions about what they wanted or what they didn't want. So death is the one thing we all have in common, yet we often don't acknowledge the importance of talking about it and talking about it ahead of time. So, what has some of the research shown us? Well, when we all do get around discussing it, we know that most people will say they want to be at home with their loved ones. They want to be where they're comfortable. They want their pain and their discomfort managed, and they want to have their spiritual values honored and respected. So why are these discussions important? Okay, 90% of people say that they're talking with their loved ones is important, but very few have actually done it. And those who make those efforts to speak with their family, so they're not burdened with tough decisions. And we know that family members who have had a discussion like this, they have less grief. Why? Because they know that they are doing exactly what their family members want them to. There's that degree of relief that, we gave mom exactly what she wanted. And I wanted to bring up at this point too, I have a lot of slides. I may go a little quick with them because I find often that, I want to add this, I want to add that. There are going to be a lot of resources that I bring up. And at the end of this talk, I'm going to email to Leah a list of these resources and links so that you can all go back and access them. So if you have any questions about some of the things that I bring up, let me know so that I can make sure that I've included that with the list of resources. So we know that those that have end-of-life discussions are associated with less aggressive medical care near death, earlier hospice referrals, and that we know that those patients who have aggressive end-of-life care end up having a worse quality of life because they're having more interventions that can be painful, decreasing their quality of life. And the bereavement adjustment of those family members are greater because, we knew that she didn't want to go in the ICU, or we had these plans, but we weren't able to follow them all the way through. So it's never too early to discuss with your doctor what you want and what you don't want. and for your family to hear you say over and over and over again what is important to you. Because the more you say it, the more you'll have family members that'll say, wow, she really means it when she talks about not wanting to be intubated, or, oh yeah, we get it, mom, you don't want this. So these discussions are really important. So where is it? So why is it, when I go back to those discussions that I've had with cancer patients, have difficulty with their doctors? I've been to a couple of end-of-life conferences where we poll the doctors going, why are we not talking about end of life earlier with our patients? I've had hospice or patients who wanted to go on hospice and had to ask their doctor 3 and 4 times for the hospice referral. So why are they reluctant to talk about these things? So in surveying doctors, we find that often they just haven't had the training. They're not comfortable or have the time talking about death. And this is often evident with some of the newer physicians that come in July, and you have to have them come and pronounce a death, and they haven't had that much experience with that. Uncertainty about the accuracy of timing, because so this fear of harming the patient, it goes back to some of the things we even hear patients say about talking about death. Talking about death does not make it happen. And we can reassure doctors of that too, but often families think of that too. We don't want to have them give up hope. It doesn't extinguish hope when a patient knows exactly what's in front of them, and it helps them to make better choices. Sometimes, doctors are frazzled and they don't want to deal with the emotional and behavioral reactions of families. That's why it's important to bring it up yourself sometimes, to say, look, this is something I want to understand, what death will be like, what roles can I have, and how can I affect that change if I don't know what it's going to be like. Patients fearing abandonment. That's usually not the case, especially in those patients that are transferred to hospice. We'll go into that a little bit later, but most patients just want to know what the truth is and what will happen and how it will happen. And then this unrealistic expectations or poor prognosis. Sometimes there can be this inability both for the family to understand the limitations of treatments, and the doctor isn't as realistic as they should be with establishing those goals. And remember, language, I know I have another slide coming up that says this, I'm going to say it early. Language matters. Sometimes we hear things like treatment or cure or comfort and care. So understanding what those words mean, they can mean different things to different people. So that what the treatment, what the goals of the treatment are, and that treatment isn't a cure. Treatment is something we can do in the next phase of the disease. So what are these? Oh, I'm going the wrong way, aren't we? Hang on, I'm looking at two different, I got two different programs going here. Here we go. So what is an advance directive, and what is it really meant to do? Remember that an advance directive is really just that document that's going to step in if you can't speak for yourself at some point. So if you're incapacitated for whatever reason, and remember, it can happen, where many of us as we age are dealing with multiple chronic illnesses, and cancer is often a chronic illness because we're dealing with one treatment after another and then another laid on, and you may already have a number of other illnesses attached to your current diagnosis. So we want to make sure that any of us can have anything happen at any time, a stroke, a cardiac condition. So you want to name someone who is going to be that person to speak for you if you were not able to speak for yourself. Remember, it's an ongoing process. I'm going to go back to this again, but it's something that people will say to me, well, I've already done that. Well, if you've already done it, sometimes people do it involved with their trust. I don't know how lawyers got so involved with this medical business when they were doing trust, but it's a very straightforward document. It's always pretty much the same. If you've done it that way, go back to it. You should really look at it every year, or when your current health condition changes, to promote conversations not only with you, but with other members of your family about what they may want or not want. And you can change it at any time. It's simple to do. We can put some addendums to it. You can, if you've checked it this year, you can sign it again and say, well, I wholeheartedly stand by everything in this document, and this is what I want. So who should be this person that makes the decisions for you? Often we're going to specify our spouse or maybe our children. But remember, sometimes they may not be the best people. Sometimes people will choose someone with a medical background or with some knowledge, but you want someone who can really verbalize what you want, and it's going to go to bat for you if there is an issue. Remember, sometimes these can be crisis situations. So you want someone who's calm, and maybe you have family members out of state. So maybe you want someone who lives nearby. I've had patients who had a neighbor, who they were very friendly with, who made an amazing advocate for them. So you can name more than one person. And you can also say who you do not want to be your advocate. So again, language matters. Don't just say, well, I don't want anything extraordinary. I don't want to be a vegetable. Be specific. You may think of somebody, Aunt Mary had an, ICU admission and all of these high-tech interventions, and I don't want any of that. Think of something like that will help get your discussion going. And I have a number of slides here that some of them say the same thing, but they say them a little differently. So I'll go through that a little bit. And when we talk about what we're going to choose and what are some of the options, that will help us to understand. What I've done is I've included a couple little bits of samples of advanced directives, so you can go back, maybe redo it or add to one you have, or maybe do an addendum to what you have. Some of them are a little bit better than others, and helping with the language to understand what's most important. Now, living in Hollywood, we sort of have a pretty bad representation of what death and dying can be, or what this CPR or really means. So often in the medical programs, we see these big full codes, and they put a tube down and they're intubated, and 20 minutes later the tube's out and they're talking, and then everything's wonderful at the end of the program, and they're going home. And that doesn't happen in real life, unfortunately. So I want to have a very realistic expectation of what happens in a full code, and that ribs are broken, and that very, very few people go back out. We just had the football player in Buffalo, a 20-something-year-old football player in great physical shape. He recovers. People through the 30s and 40s, but majority of people, especially those elderly, are not recovering from most CPR, or especially CPR that happens out on the street. So keep that in mind when we're talking about our what we want and don't want. And this is another reason why if we filled out our advanced directive in our 40s, maybe when we're in our 60s, CPR and a full code isn't the best choice for us. So we talk about consultation and collaboration because we're hoping that we have a doctor and a healthcare team that's working in that way, not authoritative and not someone who's directing what you should and shouldn't do. I have to say, I do a lot of patient advocacy and end of life work now through my practice, LA Patient Advocates. And I can't tell you how many 90, 94-year-olds that are, deciding to go with immunotherapy or radiation therapy. And why have you decided to do that? Well, the doctor said I should, no reason, not understanding and not is going with this authoritarian approach. So you want a doctor and a caregiving team that's going to consult with you, explain to you what the options are and what they really mean for you. When it comes to end of life conversations, make sure that understand that you may not get to the place you want with your doctor the first time. Remember, Medicare pays for end of life consultation. So if you have not done some of these documents, or you want to update them, or you're with a new physician and you want to discuss end of life with your physician, know that you can make a separate appointment. Medicare will pay for it, and you can explain what it is you want at end of life and get that insurance from your physician that they're going to be there for you and help and support you in your decisions. Let them know you want to discuss these choices and discuss some of the options that are facing you. Treatment options, where will it lead? What does it mean? What are the percentages, and what is the quality of life? Sometimes doctors need to know what it is you're willing to put up with. If you've got a milestone coming up, a wedding or a birth, let them know. Let them be involved with some of the planning. They really, truly will be appreciative for that kind of information too. That kind of information is going to help them to know what they have to tell you and when. So this is just some other prompts to help you get some discussions going with you and your family of different things. Different people have different trade-offs. I do a lot of work we're going to talk about a little bit with end of life options. And some people, if they're in bed and not in pain, then they're fine. Some people, if they're bed bound, then to them, they can't get out of bed, they can't take care of themselves. To them, that is a quality of life that they're not willing to put up with. So each of us is going to be different in terms of what we want and what we don't want. And that may change as things go along. So pretty much the same thing, different goals, different ways of approaching it, and helping you to forge out what it is you really want to say. The other thing that's important is to make a video. If you've got family out of town, or maybe there are certain things that are really important to you that you absolutely do not want, make a short video. I think it helps to reinforce that your thoughts on this are long-standing, that here, look, this is mom and she really feels strongly about this, and we can get behind her and support her in this. The other thing we realized through COVID is that it's not always, as much as we have all this paperwork and we're going to take it with us to the ER, when the time comes, often they're not shuffling through all the paperwork to find out, oh yeah, what did she actually have written down? What was he really thinking here? They're going to talk to that the advocate or the person noted on the advanced directive as your why am I losing the word here? As your medical advocate. So they're going to call up and talk to that person. So in the end, that's why it's important to speak to this person. It's about having those people prepared and understanding exactly what you want, not just having the paperwork done. So you've got to have both, so that so that everyone is prepared. And the benefits are many, 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 because not only are your wishes going to be honored, there's going to be less confusion and family conflict. And we've all heard stories of everybody, daughter A wants to do this, and daughter B goes, oh, I know this is what she would want. If you've talked about it, you have it written down, your family is going to be able to come together and honor your wishes. For you, you have the feeling of safety, that you know that not only is your family, but hopefully your physician going to advocate for you at the end. And I think often we can get really good physician-patient relationships through this ongoing discussion. And if you have a physician who's not willing to have these kind of discussions, it's time to look for another physician. One of my favorite books, When Breath Becomes Air, he talks a lot about, chronic illness and how our feelings about death, that was a one-time event. The terminal illness becomes a process. And I think this really does apply to chronic illness too. So there's many people with chronic illnesses that maybe at the beginning, they felt one way about what they wanted at the end. And maybe, after 10 years of fighting certain diseases, they may feel differently about it. So don't hesitate when your feelings change to let people know and redocument it. And like I say, bring out your advance directive and sign it again at the bottom with a new day. You'll often find that your advance directive, whoever is your healthcare advocate, may have moved or have a different phone or anything else. So I'm going to give you just a couple of samples of what some of them look like. There are many different. This is one of the California Hospital Associations, a lot of them. And when you go to the, I'm going to send you to the web link for this one, and it's pretty straightforward. I'm not going to show you all the pages, but I want to show you the this, and then here's the opposite one. This is one, it's really aimed for like a 6th grade reading level. But what I love about it is it's just exactly like the California Hospital Association, but it helps to really explain, if you're not a medical person, some of these decisions that you're going to have to make are explained much, much better. So we're going to talk about making these medical decisions and quality of life things, but it's a great little advanced directive for that, for people who don't really understand what they're being asked to choose sometimes. But that's what we're going to go into now. What are some of these choices? So before we go into all the end-of-life choices, I want to say a little something about dementia, because I often have people ask me in these kind of talks, like, oh, I've got all this paperwork done and we've figured out end-of-life choices, but what happens if you have dementia? And remember, there's many kinds of dementia. There's Alzheimer's, and then there's a vascular dementia that people often get from mini strokes and strokes. Sometimes people will seem like, oh, wow, she must have early Alzheimer's, or she's very forgetful. But sometimes the dementia we get from little mini strokes or strokes, it stays the same. It doesn't advance like Alzheimer's does. So, but, the way my screen is set up right now, I'm seeing faces and not always some of my facts here. But that right now, especially with the number of people that are going into geriatrics and growing older, that 1 or 2 adults now die from dementia. And many people can live as long as 10 years after the diagnosis. 60% of Americans with dementia are in a skilled nursing facility of some kind. And they often say, oh, mom didn't want to be this way. These are a lot of the calls I get are from people who say, well, this is not really what she wanted at all, but they didn't make decisions. And so I'm going to show you just a couple of things. Compassionate choices is a nonprofit organization that I work with, and I'm going to give you the link to their website as part of the resources. The Compassionate Choices is a nonprofit group that has worked hard to help get people talking about death and dying and improve our end-of-life experience for everybody, whether it's dementia, whether it's the overuse of aggressive care, whether it's being able to use medical aid in dying, or about some of the other end-of-life choices we have. And dementia, they've got some wonderful dementia tools on the website. So both talking about dementia, how it can be dealt with, some of the tools you could use if you're newly diagnosed, and also a decoder to understand what you want and what you don't want. What I'm recommending is there's a couple of great dementia addendums that I would say go to, look at them, and then think about what you would want at different stages of dementia. Like in the beginning, maybe somebody can't find their way around, and these are the patients that maybe end up on a locked assisted living facility, but they're still eating, they're taking part in life there. But then as the dementia grows, maybe they're not recognizing people, and then it gets to the point where they're not eating. And so oftentimes people can say, well, at a different stage, I don't want to be fed. Or, I've written in mine, if I get to a point where I don't want to eat, I don't want to be fed, I don't want antibiotics, I don't want interventions. And you can specify these things. And again, I would say it's very, very important that you specify them and discuss them with your family. When you have the family's backing, yes, you can do that. If someone's in a facility, you can withdraw food and fluids. Right now, very often in these facilities, these patients are, they do urines every week and all. Years ago, pneumonia was a way that often took these patients early. So we can make sure these patients are having comfort measures and have all the comfort care that they need, but we don't have to give them antibiotics. We can help to let this infection take them peacefully and comfortably. So there's a lot of options you can use. You can write a personal statement about what you want and don't want in dementia and sign it. But these are things you want to be very proactive about. And again, even if Alzheimer's is not in your family, you may want to write it out in case it's a dementia that's caused by a stroke. So won't go into it much more than that, but if you have questions, it will be in the resources. There are a couple different dementia addendums. So the other document you should be aware of is the pulse. So you can have all these advanced directives filled out. You can show up at an ER and even have your advocate there, and they may ignore you because unfortunately, some of our ERs are religiously based, and they're going to have their protocols, and sometimes they may not always listen to what you want if you have a do not resuscitate. And so we have those kinds of issues routinely with certain ERs. The POST stands for Physician's Orders for Life-Sustaining Treatment. So if you're someone with a chronic illness or someone who has maybe in the next year, there's a possibility that the patient could die. Doesn't mean they are deemed that way. It's just that there are maybe other underlying disease processes going on. This document is signed by the doctor. It's like the advanced directive in the sense that you're marking down what you want and you don't want. It's meant to be filled out with your physician together. I give you examples of it so you can understand what's in it, so you're prepared when you go and talk to your doctor about it. It applies in emergency room just like your advanced directive, but because it's signed by a physician, it's the one thing that the EMTs will honor And most 99% of the ERs will also honor it and will abide by it. So I really suggest that you have it. You can always destroy it, start over again. You can cancel it out at any time, but it's a very good document to have. And I know that, so it's asking about like comfort measure, medical interventions. Do you only want comfort measures, or maybe you just want limited interventions in terms of maybe we're not going to intubate you, but we can give you if you're having a cardiac arrest, we can give you drugs, but not intubate or full treatment. And there's plenty of room to write also if there's other specifics that you want or don't want with these documents. In California, it is bright pink, but you can copy it and it's still honored. Usually when your doctor does it, it'll be the pink one. That's the one you want to have hanging up in your refrigerator or near the door for the EMTs to see. But make some copies if you have one and carry it around with you so that you have it if anything should happen. And a physician or a nurse practitioner or PA who's working under a physician can also fill these out. Okay. I think it was pretty much on that. And again, it can change. It's also talking about artificial nutrition, feeding tubes, things like that. So that's the post. So the other topic is pain management. I want to make sure that everyone is making sure that their pain is being adequately addressed. I can't tell you how many times I go in and then I hear, oh, yeah, but I tried that pain medicine, then I got constipated, then I didn't want to try that. And people are going around in pain and not getting proper pain management. First of all, this constipation thing. We can do tons of different things for constipation. And there's no excuse for anyone to say that constipation is what's holding you back from getting good pain management. So, and if you have a number of chronic underlying issues, we want to make sure you're seeing a good pain specialist that's looking at all the medications you're on and finding out what's the best pain medicine for you. And remember that the pain management works best when you start out very, very small, and then we can increase when and if we need to. And it's better if you're taking things early for the smaller amount of pain than waiting until it's really bad and then take it. So it's really, really important that so many other things are affected by the pain and the pain experience. So, and especially if we're talking about end of life, don't be afraid of painkillers or addiction or I don't want to be woozy. When we take stronger pain medicines, we know that patients within a few days to a week are going to adjust to them. And if that's really the factor, and there's a point where you are, we can also give other medications that will help you be more alert. If there's people that are coming into town you want to see, there's other medications that we can also give. Sometimes at end of life, we'll give steroids to help people really have that time with family members if that's what they're really looking for. So leading up to all this, what are some of these end of life options that we're really talking about when we're talking about checking off boxes and making decisions at end of life? So in the beginning, we were talking about pursuing all treatment, that everybody has that right and that autonomy, that they're going to do all the treatment they can whenever they can. But we all have an outlook as to we're going to pursue every kind of treatment possible. But at any point, you have the right and the ability and the autonomy to make a decision to discontinue or decline certain medical treatments. Okay. Then we go into palliative care. those two are not exclusive. Palliative care is one of the ways I like to explain it too, because so many of us are dealing with chronic illnesses and so many diseases on top of other diseases. Even sometimes the long-term effects of cancer treatment can leave us with a lot of symptoms that need to be dealt with. And getting a good palliative care assessment doctor can really make a difference. And it can happen at any stage of a disease, and it can be a supplement to also taking current treatments. It is paid for by each doctor visit by the insurance. I know that there is a number of hospices out there that are saying, oh, well, we offer palliative care, sign here. But I want you to be very, very careful in that respect. Some of them are having patients sign for palliative care, but are actually signing them on to hospice and billing Medicare that way. And I've seen that a number of times. Sometimes they're signing you on for palliative care, hoping that you're going to go with them when you go into hospice. A number of the larger medical centers have palliative care teams that help to assess patients and offer symptom management. So one of the problems that I've found lately is that there aren't enough palliative care teams, and it can take a while to get into a palliative care program if you want to do just symptom management. So think ahead, make those appointments and all. But if someone's asking you to sign for palliative care, please, 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 call me or call the other nurse navigator at WeSpark and make sure you understand what you're signing. Because I've had a couple of patients that have been, well, I don't know if it's a patient, it's really Medicare at this point that's, boonwaggled out of this whole thing. Doesn't really, in the end, it probably doesn't affect the patient that much. So the difference between that then is hospice are patients that have a prognosis of 6 months or less. They're expected not to recover from one of the multiple diseases that patients seem to have at this point. And the care that they're getting on hospice is comfort care, but we're not offering them curative care. And it's paid by Medicare, Medicaid, and your insurance. I'm going to go into hospice again a little deeper, but I want to talk for a second about one of the other options, which is voluntary stopping of eating and drinking. I have a number of patients who, because of one factor or another, they don't qualify for different end-of-life options. So who is choosing to stop eating and drinking? And first let's think about what happens at end of life, because to us, we think, well, that's starving and all, right? But when people are close to death, or they're beginning that to be actively dying, or even sometimes you'll notice patients in that last year or so that they're not eating as much. Family members are bringing over food and they're trying to nudge them on to eat a little more. And what happens is that our bodies start to shut down. And one of the first areas that shut down is the GI system. They start to slow down. And so offering more food and fluid to these patients actually causes more distress than anything else. And later on, as patients begin to actively die, adding more fluid to that, there's no place for that to go. The lungs are shutting down, the cardiac system is shutting down. So oftentimes families will ask, well, why don't we give them an IV or something? When you add those fluids, where is that going? It's going to go into interstitial. The lungs are going to fill with fluid. Patients are going to be coughing. So this is a point of life where we really need to listen to the patient and what they're saying. And we need to find other ways to bring comfort to our loved ones. So if they're not wanting more food, or, giving them small amounts frequently, giving more liquids, offering to moisturize the lips, having massage of the hands and feet and arms, playing music, offering and just being there, sitting there, holding, talking and reminiscing is more important. So, all right, so back to this patient then who's decided that they want to stop eating and drinking actively. And oftentimes these are patients who want to control their death, and they haven't been able to use any other method. So they sometimes, I've seen this in our ALS patients, sometimes early stage of dementia who think they won't qualify for anything else. And sometimes it's often patients who are now having difficulty swallowing. So they, instead of waiting for death to come, they want to hasten the process. So the body's response will be to slow down. The early symptoms are thirst and hunger. We want these patients to be on hospice. We want to be able to offer them, you want medical care at this time, so we can give them medications. We can give them medications to help dry things up. We can offer moisture. Sometimes we'll put like a vaporizer in the room, so there is more moisture there, and helping them to get through those first couple of days. And what then begins to happen is the kidneys shut down and they go into a coma. And usually death is anywhere from 1 to 7 days. 1 to 4 is the average. Usually they go into a coma. So then one of the other options then is palliative sedation. And palliative sedation is physician directed. This is controlled in the hospital by the physician. Typically, this is pain management centered. These are the patients who maybe have allergies to certain pain medication, or sometimes people have receptors that just don't work as well as others, or have a great deal of disease and pain that we're not able to control. And so what we're doing is giving them pain medicine to the point where it sedates them, and continued sedation will then result in death. But it's we didn't hear about it as much, but we have, since the beginning of end-of-life options and death with dignity, you do see palliative sedation a little bit more, but oftentimes it's those severe pain management cases where I've seen it. And then we're going to go into hospice a little bit to understand what hospice is and what hospice isn't. And they're not all the same. They are all can be very different. So hospice care and different parts of the country is different, but we used to think hospice was a place, but it's not. It's more often, especially in this part of the country, other parts of the country have more facilities or places where people can go if they don't want to die at home. I try and encourage people to die at home and not to worry about that as a factor. But these are patients that have 6 months or less expected life. That means we had to go with something. Nobody knows exactly when, and especially when we're dealing with some of the Alzheimer's patients. But 6 months or less, we wouldn't be surprised if they died. At the end of 6 months, if a patient is still alive, what the hospice does is reevaluate them. How have we seen their decline? Have they lost weight? What are the lab values now? What are they needing? And then we can up them as many times as we need to. We can increase that. I've had patients that were active. Maybe they had active disease, but they decided they didn't want any treatment or any surgery. Patients that were still going out and playing bridge and coming back, and the RNs would check on them each week, make sure that symptoms were managed. And the great thing about hospice also is hospice thinks ahead. We know what's going to happen coming up. So what we'd like to do is make sure that medication, equipment, things that the patient and the family may need in the next few weeks are already there. So should there be a change in condition, we know that there's nausea medication there, or there's confusion, or at nighttime that there's medication already in the home to deal with it. But again, you have 24/7 nurses on call to help with answer questions. The medication that the hospice physician orders for the patient are delivered to the home. There's no more going out and getting your family member in the car and taking them to the doctor. The doctor and the nurses are all coming to you. But that was one great thing about COVID and telemedicine visits, huh? Tell me, here we are on Zoom, right? So you'll get a weekly RN visits, and that will increase if you need it. We will have, you may have visits twice a week or even every day if we're having trouble getting a patient comfortable. At any time that you're not happy with the hospice, or you decide, I just heard about another treatment, I want to go and try this other curative treatment, you can leave hospice. Again, let me repeat that. If there's a time where you're not happy with the hospice, they're not giving you what you want, and you call another hospice, you make one phone call, and that new hospice will come in and take care of everything. And that's something I actually encourage from time to time, because for a long time, California was giving out hospice license right and left, and you didn't have to have anything to get a hospice license. So we found that there are just a lot of hospices that weren't doing exactly what they need to be doing. I have another slide coming up that gives you questions to ask when you're choosing a hospice. So I think this slide may talk just about, this may have been from a conference, but it's just about the benefit. So, and again, you need a hospice referral from your doctor, whether it's an oncologist or your primary doctor or your orthopedist or your neurosurgeon, whoever it is, they are going to send over a hospice referral. But oftentimes, more often than not, it's the patients that are saying, hey, we're ready. We're done. We want to go into hospice now. And often you'll get doctors that are saying, well, maybe not. Oh, you're not ready. I've had patients ask 4 or 5 times to their oncologist that they were ready to move over. Patients that weren't getting any treatment, and they weren't. So if you ever have that experience, know that you can call the hospice, they'll call the doctor, and usually in that situation, they will make the referral at that point. But before that time arrives, you should interview hospices on your own. Oftentimes I'll hear patients say, well, this is who the doctor, referred. But did you ask the doctor why they're choosing these hospices? And often I ask the social workers why they choose what they do. And I don't know whether it's the lunch they were brought last time, or the recent Laker tickets, or what, but oftentimes I've had patients who are specifically said, I want to go on hospice, I want to use the End of Life Option Act. And the social worker referral was to a hospice that had nothing to do with the End of Life Option Act. So the patient now was on hospice 1 or 2 months, and they realized, oh, wait, they said they were going to get me this, but they're not doing that. So now what do I do? So it's very important to check things out beforehand, and I'll give you a list of questions for that. But the hospices that have been around for a while, they're offering more than what Medicare says they have to. Everybody offers, this is what you have to offer, but others are offering more. Maybe there's a volunteer service that will go and pick up groceries for you. The physician's going to come out and examine the patient in the beginning. spiritual counselor, the social worker, if you need anything else, bereavement and grief groups afterwards, therapists, some will do occupational therapy, some have pet and animal therapy. So find out really what they're offering and what makes them different. And I think the other, it's important to note now too, we're all seeing that in all of these institutions that we're going to, there is a severe shortage now of bodies and people and nurses and staff. And we need to realize that and understand that hospices will find that too. So you want to find out, when you call them 24/7, is it going to be a real person who's going to answer the phone, or is it a service? But the hospices have been around for a little bit. You've also found that a lot of their nurses, ask them when you interview the first, how long have they been with this hospice? And some of the nurses work for some of the hospices, multiple hospices too. So we'll talk a little bit about the California Medical Aid and Dying Law. What is it and what is it not? And how do we use it? Okay, so it's a safe and trusted medical practice, which has been around now for, there's a combined total of almost 40 years. It was almost 30 years in Oregon to begin with. Oregon and Washington were the first two states to have it. But a mentally capable, you have a mentally competent person with terminal illness of 6 months or less has the right to request from their doctor a prescription for medication that if they should decide to ingest it, they will know that they will die peacefully. And this other part about end unbearable suffering, it's different for everybody. Everybody is going to have a different level of suffering and what they want. So you'll hear it called a number of things. It's medical aid in dying, or MAID. Also death with dignity. California, the way the law is written, is called the End of Life Option Act. So it's also EOLA. What it isn't is assisted suicide. And we'll go in that, talk a little bit about that in a second, but those are, so it's across the country now, there are 10, 11, if you count District of Columbia, states where it's legal. The other yellow boxes are where Compassionate Choices has organized efforts and trying to get the law passed in other states, New Mexico, Nevada, Colorado. A lot of those are fairly new. Hawaii is one of the newer states also. And just in terms of support, a 2020 Gallup poll says that just as many, 70% of Republicans, 85% of Democrats. You can see there is a strong group of Americans that are in favor of all types of autonomy is really what it is. And I think in 2015, when Governor Brown signed the bill, he had said, I don't know what I would do if I were dying in prolonged pain, but certainly he would want the option. And that's really what we're talking about is it's not for everyone, but it is an option for those who want it. So the law was passed in 2015, it went into effect in 2016, and we updated it in January of 2022. So I know every time people go, is that really law? Or I'll get calls from people that my mother said she wanted to use that law they have in Oregon. And then we went online and we saw, oh, it's a law here. There has recently, somebody filed in federal court to try and get rid of the California law. Surprise, surprise. And that's another thing. Compassionate Choices has a very strong legal department. So if there's anybody, a number of legal issues that I have seen come up with the law, or even with other healthcare issues, we go to the Compassion and Choices legal team, and they've really been wonderful about helping. So we've already, battled a couple of laws, but I know the same people that have gone after abortion are, come after us in terms of what we're requiring. And you'll see that there are a lot of safeguards and requirements that any doctor, no doctor has to take part unless they want to. So you have to be a California resident, 18 or older. But I'll tell you, there are a lot of residency rules that have been waived, like Oregon, Vermont just waived theirs. My doctor has never asked. It's something I do when I assess a patient, are they here? Most of the time, patients are already here and they have a doctor or they've gone on hospice. So it's not hard to establish residency if you want to bring someone to California. 6 months or less. And in New Mexico, if you're already on hospice, then you already qualify. Here we go through, we want to make sure that they also qualify, but most patients on hospice. But I have a few patients right now that have gone through the process and got the medication, but they're not on hospice yet. So generally I try to get them to also be on hospice. And actually I get calls from City of Hope. Sometimes City of Hope doctors help, they have a program there, social workers and navigators that help them through the system. So sometimes patients will get the medication and they'll call me and say, oh, they want to take it right away. Can you be there and do the pronouncement? And they don't want to deal with hospice. So usually I think it's important to be on hospice, but in those situations, we'll just go and help them. So you've got to be able to make a medical decision. But it's amazing. They'll say, oh, do you want to take this chemo? Do you want to have this surgery? And then someone asks for end of life option to go, oh, are you competent to make those decisions? Well, I just made those other decisions. So, but there is a part of the form where one of the doctors have to say, is the patient capable? And in Hawaii, you have to have a psychological evaluation. But here, just if we think there's an issue, or sometimes I'll do a little mini mental with my, 90 plus patients. So then this ability to self-ingest, what does that mean? And so it means that someone like me can be there to mix up the medication because it is a liquid, a powder compounded in a liquid, and I can hand it to you, but you have to drink it, so the medication is all oral, there's no injections or anything, and it's about 3 ounces of liquid that we drink. We can put it in a feeding tube. If someone has a feeding tube already, we can put it in the bag and then they can open it up and let it get going. Or if it's an ALS patient, there's a number of ways to get going. In patients that have a lot of abdominal disease, or maybe the GI system isn't working as well, we can also do rectal administration. So we set up like a tube, but then we have to have these syringes, and the patient has to be able to push the plunger on the syringes. So done it all those ways. So the requirements and safeguards are 2 verbal requests to the prescribing physician, the person who's going to write the prescription, by 48 hours. This is the one big change from we redid it last January. It used to be 15 days. So, back in the early days, you were going from doctor to doctor to find a doctor who would prescribe. You got a patient who's actively dying, very, very sick. And often by the time you got, your first doctor visit, then you had to wait 15 days. Patients were not surviving. And that's really what we did. We went back to the legislature and said, look, we're losing too many patients in this long waiting period. And New Mexico had just passed, and they were 48 hours. And so we were able, with the help of some of the physicians and the California Medical Association and some lobbying, really telling them, no, not everyone most patients, I always say, oh, it'll take, a week to go through the whole process and 10 days. And most patients then, once they have the medication, then they're waiting till the right time. Just knowing that you have it brings a lot of comfort. But there are patients who are actively dying and very sick, and as soon as that 48 hours of the medication is available, they want to take it. But there's a good number that are waiting a month or till the right time, until they've finished what they need to finish. So you have a request that the patient signs, that 2 witnesses sign, saying, oh, this is who I think it is, and that no one's coercing him to sign it. And then we have a second physician who is just confirming that the patient is eligible, the patient understands what the risks and the benefit, and understand that there are other options. So it's 2 physicians, one you see twice and one you see once. Sometimes we'll get the patient's own primary physician, can be that second physician that who confirms eligibility and informs of all the other end-of-life options. So some of the other, I think I included this. I think sometimes people want to know, like, well, we've heard this, we heard that. It's illegal for anyone to coerce anyone. A lot of the this recent lawsuit talks about disability and those who don't have means, or insurance company pushing them. None of these things have ever been documented in any case in Oregon, or any of the years that we've done it. If you put together all the different jurisdictions, over 40 years of combined, and there has never been. Remember, most of these patients are actively dying. Most are already on hospice, so they've already gone through every procedure possible. Or if they had an option, they definitely want to live. But knowing that they're actively dying, they want to be able to take some control and have a way to control their own death. Remember, we talked about, how did people want to die? They wanted to die at home and peacefully. And definitely this is what End-of-Life Option Act does. People drink the medication. In 4 to 8 minutes, they fall asleep into a deep coma. They don't feel anything. And usually within an hour to 4 hours, the patient dies very peacefully. Wills, contracts, insurance are not affected. The death certificate states the hospice, the underlying disease. So there's no mention of End-of-Life Option Act unless the family members mention it to other people. So I think that's one of the changes I've seen lately. I think in the beginning, people used it, didn't tell anyone else, but now there's a lot more of, oh, I heard, Susan's Uncle George used this, and somebody tells somebody else. And, a lot of the work I do involves going into some of the assisted living facilities or different kind of facilities, and, they've told other people. And so that's one of the factors that so I have seen an increased number of people. This year will be a much bigger number. And it makes it easier now because we can use telemedicine. So you're able to be able to do those visits via telemedicine and not have to drag yourself around. So it really is important to use medical aid in dying. It's not suicide. People who commit suicide never have their family members around and watch them. They're not going out peacefully. It is often violent, and they're not mentally stable. Medical aid in dying are people who desperately would want to live, but are actively dying. And this way they get some control over it. But it's very important. We're always seeing assisted suicide. And it's really helpful to clear that up and let people know that that's not what we're talking about at all. This is an alternative way for patients to be able to go out peacefully and comfortable and with some control, for sure. So, one of the other options that is if you a doctor, you may talk to a doctor and he can say, okay, I don't do that, or you may ask your doctor and says, why I don't do that, or I'm not allowed to do that at, Catholic hospitals. So if you have somebody at Providence or St. Joe's, they're going to say, oh, I can't do that. Now, I have a internist who's in one of the medical buildings in St. Joe's, and she's done it many times. So, but if you, they can't prohibit their staff from participating in it, but they can say, oh, you can't do it in this hospital or this space. Well, it wasn't meant to be done in a hospital. It's meant to be done at home. So, but one of the changes with the law was that you're required to post on your website what your policy is and provide information. There are a lot of hospices where they won't bring it up. If the patient brings it up, then they'll give them information. And that's a lot of the work I do. There's about probably about 12 hospices now that if a patient asks for it, they don't do it at their hospice, but they'll call me. I'll go in and I coordinate with the patient, with my doctors who we do telemedicine. I get the medication, and then when they're ready, I'm there when they take the medication. There are a few hospices, maybe there's probably 3 or 4 right now, where they do have physicians as part of the hospice who will write for the medication. So if you're on this particular hospice, Medicare is paying for everything else, but Medicare won't pay for the medication. So you're paying for that separately. But I have a great pharmacy now with the lowest prices I've ever found. So definitely call me. Even if you're with another hospice and they're offering it, I can get you the better prices. You just found this great. But any individual, any nurse. So if you're on so the other question, when you're with a hospice, and if this is something you're interested in, you want to ask them, what is your policy? Oftentimes skirball is one where, they won't let the nurses be there when you take the medication, and a Roz room is like that. So there's a number of them that are just not cooperative at all. So even if you think you may not use it, you want to know what your options are going to be, and you want to have staff members that are going to be supportive to all your choices, no matter what you end up choosing. So these were the changes that we made in 2022. So we changed the waiting period from 15 days to 48 hours. Again, it was hospices and hospitals had to provide transparency. We had hospices that were out and out lying to patients about what the laws were. Oh, that's not available, or oh, you have to go to an ethics committee, or just out and out lying. So, the problem with these changes is there's no one to really enforce these laws now. So it's great that we change them, but big deal. No one's doesn't always pay attention, for sure. So even if you ask your doctor, or even if you're on hospice, you ask them and you say, look, I want to use medical aid in dying. They say they're not participating, as they're required to document and refer. And that was one of the lawsuits that we had recently. But most of them will do that. Ask them. If they say, no, we don't do it, just say, please document this in my chart, and then they can refer you out. The fact that you asked this first doctor, even if he didn't do it, that starts day 0. So for some patients, that can be very important. Patients, who are actively dying or in a lot of pain, when they do finally get to that person who is going to help them, knowing that it was documented in the chart means that we don't have to do a waiting period then. So, and I wish there was, yeah, oh, I went the other way here. And we know that what was happening before, we had a third of terminally ill adults who requested it died before the 15-day waiting process. So it was important that, you know, even though we, it's not, we know when we have to go quickly and we can get it done quickly. And that's what's great about telemedicine now. So, and so if you ask your doctor and your doctor says no, there's a lot of reasons why doctors who don't support medical aid in dying, but you should ask why. You know, is she allowed to prescribe? Sometimes those with California Dignity Health and Adventist don't allow their doctors to practice it, even if they went out. If you're in a secular system, you know, that does allow the doctors to prescribe, Kaiser, UCLA, Cedars, you know, you want to get them to change or ask them, you know, we can help you. So ask them. Sometimes I've had doctors say, oh, you're my first patient who ever asked for it. And I've had a number of doctors who have come to me and we've helped them go through the steps of what they needed to do. It's quite possible they didn't even know. It's not like doctors are trained on it or know exactly what to do. So we can support them. Compassionate Choices has a doc-to-doc number. We can help refer them to a doctor to support you. And so ask the doctor if they can refer you to another doctor that can support you. Or sometimes they'll just say, I'll refer you to hospice. And they think, well, hospice will take care of it. And if for some reason you end up on a hospice that doesn't, you have to let us know. Ask that they document your request and see which hospice they want to transfer you to. Definitely call me, let me know. Some of the hospices, like I say, will support you and your choices. And there's also, you know, a practice like mine where we can get the doctors, you can stay on the hospice that you want, and we can still get doctors to help support you and get what you want. So what is it in practice? I mentioned a little bit about it being a powder. First, they take an antiemetic, take some Reglan and some Zofran about 1 hour before taking the final medication. And the medication, again, is like 4 or 5 drugs mixed together. Huge dosages of phenobarbital, fentanyl, what else is there? Digoxin. So there's medications to stop breathing and to stop the heart. The medications are bitter. So we ask patients in that hour while we're waiting to do some sorbet and popsicle to get the mouth a little colder. So it'll go down a little bit easier. And yeah, the common compound that we use is DDMAPH. So it's morphine, digoxin, amitriptyline. And then, as I said, the time to death to ingestion varies. Sleep comes from 4 to 8 minutes, especially with this new updated compound that everyone's using. And then death is, I've seen it in 30 minutes to a few hours. From every once in a while, it can go longer time, but that usually has something to do with patients with extensive abdominal disease. Remember, these medications are absorbed in the lower GI system. So for patients who haven't eaten for a long time, or that's just not working the same way that everyone else is, it could take a long time, but it works. It will always work. I've never seen it not work. So just some quick statistics from Oregon over the last years. Again, you get a third of the patients who get the medication say, oh, some of the things that I was weary of about end of life didn't come to pass. My pain has been managed, I'm comfortable. And so they didn't take the medication. sometimes they die, again, they die before they got it, but some had the medication, just chose not to take it. Most people were over 65 and had cancer. I see a lot now with Parkinson's and some heart disease, and but in over 25, 30 years, no instance of abuse at all. It's not a simple process. There aren't a lot of patients that, like you say, don't always know about it or understand how to access it. And sometimes it depends on where you are in the system and how you find out about it. I think that's often the call we get is, how do we ask and how do we get to that? So, here's the questions about hospice. I thought that was up there. How long have they been certified, these hospices? Do they have a real person on call 24/7? Sometimes they just use a service. What other benefits? And then ask them about their end of life policies, because some of them do now, they want to keep medical aid and dying in-house. Before, when I didn't have my doctors on board to help me, I would have patients change hospice and go to one who would write the prescription. So there's a lot of different ways to ask about it, and ask about what other options they support, and would they be there for you. We have seen in states like Oregon that there's having a medical aid and dying law. We know it increases the conversation. So we know we have better palliative care and better hospice care because people are talking about it more, even if they're not using medical aid and dying. It has increased the end of life option discussions that doctors and patients are having. And we hope we're reducing barriers to get people into hospice earlier and know that, this is an important option for patients to get to. These are just some of the statistics that, there are forms that get filled out that go to the Department of Public Health. They don't have they have the patient's name, but that's never kept. They just want to know that what percentage were on hospice, how old were they, how many. You can see in the early years, there weren't that many, and now we're getting to the 20s, it's going up, and it'll be over 2,000 last year used medical aid and dying. So definitely in the last year, I've seen my practice alone has tripled. So people are asking for the medication much more frequently than they were before. Yeah, you can see the numbers are going up. So we don't have 21s yet. So just to know then, as you can imagine from what you heard, so Alzheimer's, you can't use medical aid and dying. You can't, pre-ask for anything. This is something you will ask for when you are 6 months or less out. So if you've already been diagnosed with dementia or Alzheimer's, it's really the pulse, voluntary stopping of eating and drinking, the addendums, there are other options that are really important to look at. So go back, look at your forms, every few years. I always talk about the 5 Ds, every decade, but I think we should be doing it more than that. If there's a change in your diagnosis, a death in the family, a divorce, or a decline in your health, I think sometimes we think, oh, this is what we would want to do, but it changes as we change. And even if you decide not to change it, think about adding addendums, and you can write what you want. You can put a little bit more there that's a little more descriptive about what you thought you wanted before, and maybe something you've talked about. So that's it. If you have, this is my last little, all the I think things change. It's the very pretty thing that we'd all like to think would happen, but maybe not. But you know, it can be tough to always say what you want and get what you want. But the more we talk about it, and the more we talk about it with our families, I think the better chance we all have of being heard. That's for sure. All right, I think, okay, so this is just some of what the website looks like. I'm not gonna spend any time on these slides, but I'm going to send you links to all these different places that I've talked about. This is part of the Compassion and Choices website. You know, there's just so many tools there that you'll see. And I'm going to send these sheets with these websites and addendums. Well, the other thing is, where do you store your advanced directive? There is a cloud you can store that in. California Department of Public Health has a cloud. You can put it on your phone and carry it with you. And just remember to maybe have that little go bag available for you and your family. Don't leave it in a safe or with your trust somewhere, all right? Please take my number down and call me. Anybody at WeSpark can call me anytime if you have any questions. I have a website. It's not really updated lately, but if you have any questions, what didn't I go over for you? I know it was a lot of slides.
Hey, Karen, can I ask a quick question?
Sure.
What's about the average price of the cocktail now?
Well, right now, if you're just paying for the drugs, we were paying $500 to $700 for a while. And it was $500, then it was $700. And then I just found a pharmacy in Ventura that just charged me $330 for 2 patients I'm working with right now. So that's
Wow.
why I say, if you're on a hospice and the hospice says, oh, we'll write the prescription, you just have to pay for it. Let me know, because I can send you to it's a great little pharmacy, and they just really believe in it and want to help. So when I do it for the with the doctor visits and the medication, it's $2,800 for the whole thing for right now. And that kind of service with doctors and all can be anywhere from that price to $3,000 something.
Right. Yeah. Okay. Yeah. Thank you.
Does Medicare cover it?
Pardon?
Does
No,
Medicare?
doesn't cover it, because Medicare is a federal program, but make sure you get the receipts, because I have had some people take the medication receipts, put that into their insurance company and get the medication covered. You never know. Medi-Cal, some of Medi-Cal, because it's a California program, Medi-Cal will cover it. Kaiser was always wonderful from the get-go with end of life. And I don't know what they're doing lately. They have a great navigation system. If you have any trouble with Kaiser, let me know, but they have a great program. So I don't know how much they're charging for the meds, or whether they're including it now. So yeah.
But can't you just make your own cocktail?
No, that's the problem.
No.
If you make your own cocktail, what's going to happen is 2 things. One, you'll probably vomit or wake up.
Yeah, right.
Okay. And second is, anyone else in your home could get charged with homicide. So what this does is this makes sure that everything is legal. You've signed the form. All the doctors have signed the forms. Everything is safe and legal. And we know that this cocktail, this combination, will work. It works every time. I mean, it wouldn't kill an elephant, actually, I think. I mean, it's just such a huge amount. But, there's a whole academy now. There's an academy of clinical medical aid and dying physicians, clinicians that I'm involved with. And I was just at their conference. So we've seen over the last few years how, you know, in the beginning, we were using Secanol, which was the old, sleeping pill, and we'd open every capsule, and then, you know, that was $3,000, and that went up. And then we had a number of doctors up in San Francisco that were really working to say, okay, what do we need to happen? We can only use the GI system. So what's the best method to do it? And this combination, I'm one, we've all been involved in a research project. We'll put in our patients, you know, information, nothing that would identify them, but just to explain like what happened, you know, how long was the death afterwards, so that we're using the best possible combination of meds we can that is most effective. So most times the patients die within an hour, and literally they fall asleep, and it's very, very peaceful. And I think it's very helpful for the family to see this. You know, if you've been with a family member for a long time and seen them suffering, and as hard as it is to say goodbye, to watch them, you know, die peacefully is very important, I think. Yeah.
Karen,
I have a question. I'm sorry, you can go ahead. Go ahead.
yeah, Karen, I have a question. I am originally from Belgium. It's one of the countries in Europe which start with euthanasia, and there is, they call euthanasia. You mentioned there that was not euthanasia. What is the difference? Because I believe the words are different. In Belgium, in other countries don't happen. In Belgium, a doctor or a nurse administrate you directly.
Yes, yes.
I see in your case, yes or no, what you mentioned, because you made the preparation, because before I was reading, because I'm a member of the group Compassion, I was reading, you take the things alone, and I read, a lot of people ask and they never take. I remember somebody who answered me in the hospital, you know, a lot of people ask to be sure and never take the thing. Or when arrive the moment, they don't want to take themselves. Well, it's not my case in this moment. I have cancer, but it's not my case. Which is the difference, the word euthanasia? Because I remember one time I said, in Belgium.
Yeah, no, okay, yeah, I know what you're asking. So yes, in Belgium and some of the European countries, they are much, Dignitas is one of the name. Yes, they will, and even in Canada now, Canada will do either way. You can take it, the solution to drink, or the doctor will give you an injection. And Europe is like that. Belgium is also, they're much more lax. Like they will give the medication for someone with depression or early Alzheimer's. Now, the way the United States laws all work, the patient, it's patient-centered. The patient takes the medication. And no, you don't have to be alone. We don't want you to be alone. We don't want, you know, we want you to be with your family. And the reason someone like having a hospice nurse or nurse like myself there is I want to make sure that the timing is right, that the medications are mixed with, you know, they come as a powder. We mix them with some apple juice. So we want to make sure that they're mixed safely. And then I can hand it to the patient or help them with the straw, but they have to drink it themselves. They choose when they want to take it and if they want to take it. I've very, very rarely have I had, you know, where I go to the home and they say, oh no, I changed my mind today. I always ask them, I say, you're going to get, you know, very sick of me asking, because I will ask, you know, multiple times, you know, is this what you want? Or we take the anti-nausea. And then I'll say, before I mix it up, you know, I can come back another day. We can do this another day. I've only had one or two patients who, you know, said, oh, I think I'm going to wait till another day. But those patients always eventually took it. There were patients who I think were more afraid of pain management, that the pain was going to be too much. and then their pain was adequately managed and they died, from their disease. And there's always about maybe a third of the patients who do that, who get it that way. Is that it?
Yeah, and the name, why? Because I remember one time I was speaking and they say, no, it's not euthanasia, that is not the right name. And I said, well, version, use, and well, France don't have for the moment. It's all the time the fighting for religion issues. But what is the difference with the American and the name they use in Europe, or maybe it's a generic name, euthanasia?
I don't know I don't know which name you're referring to. You mean like medical aid in dying or end of life option act? Is that what?
Or euthanasia?
Yeah. I mean, at the last conference I was at, all 10 countries that had end of life option act were at this conference. So
Okay.
we heard from a lot of the international voices, but it's always, yes, when a doctor uses it, it's more euthanasia because euthanasia when the doctor. That's why we use medical aid in dying in the United States, because the patient is doing it. Yes.
Okay, because in Europe and that when the politicians are fighting with that name.
Yeah.
And I know cases who people who have Parkinson and so on, and they sign the papers already, and at the beginning, if that happened, it's a person who lives in United States, but he's from Europe.
Yeah, sometimes Parkinson's patients will think, well, if a Parkinson's patient has decreased ability to swallow, then they would qualify. Because oftentimes that's the issue with Parkinson's patients. We can't say they have 6 months or less to live. But as soon as you can't swallow or at the beginning of not being able to swallow, then you qualify. So that's the difference with Parkinson's.
I have a question, Karen, if you don't mind. It has to do with the post and an advance directive.
Sure.
I have a post, my physician had me fill one out. First of all, should my advocates have a copy of that? I keep it on my phone and in my car and with me, but should my advocates have a copy of it too?
Yeah, definitely I would copy it. I mean, a copy is legal.
Okay, and then is there anything, because I'm basically DNR through the whole thing. Is there anything else other than the boxes that you check off that it's worth adding to it? Like I have just checked off comfort, focus, treatment, and I guess I kind of repeated what they said, that I don't want, but is it important to write that on there, or is it also better important to have an advance directive with it, with more specifics?
No, I think that they're both legal, but I think the pulse will supersede it. And again, you want to make sure that if for some reason you fainted or passed out or went to the ER, you want them to be able to see the pink form and you want to make sure your advocates have it so they could take it and say, look, here, we have this, make sure that they're not trying to intubate you or do anything or, do anything that you don't want. And then sometimes, if you don't want to go to the hospital and all, make sure that people in your care or people in your circle aren't calling 911 and things like that. That's the big bugaboo too, is that, you don't want to make sure that you're going to a hospital when you don't want to be.
Thank you. And then the last thing is just this with, if I'm not unconscious, which is what the post would be related to, do they listen to you if you tell them, what you want regarding pain management or palliative sedation, or is it better to have that all in writing, even if you're conscious, just so that they can't supersede you? Is it better to have that in an advance directive?
You can have both. I mean, I'd like to be able to say, yes, they're going to listen to you, but they don't always. And that's why it's
Okay.
nice to have a, an advocate that is going to speak up for you, or, make sure that you have it on your paperwork, where your doctor is, and make sure that your advocate contacts your doctor and they're contacting the ER where you are. That's one of the big problems we have right now. Actually, Compassionate Choices has started to do some great work on it, because, the number of places where religious institutions are taking over the hospital systems, and also, changing what we do. I can give you a long list of patients who didn't have their advanced directives followed and observed. And it used to be that, people would sue because the hospitals didn't do enough. Well, now they're suing because the hospitals do too much, because we don't want this aggressive treatment at end of life. What the amount of aggressive treatment that's done in the last month of elderly patients that have no reason for it, but they get them in the hospital and do all this expensive, aggressive treatment is unbelievable. And so that's the big part, is having someone advocate for you and say, what we want and don't want, and, avoiding some of those institutions that will take the choices out of our hands.
Okay, the thing for me is that I don't really have an advocate like right at home. And so in the time it may take to contact the person who is my advocate, or my doctor who may not be there at the time that I need help, having an advanced directive with me as well as the post would be helpful, is what you're saying?
Yeah, I think that would be
Okay.
helpful, and have it, written on the bottom, sign it, write a little note with it that, this is that you feel strongly about the things that are written here, and this is what you want and don't want, and you expect any institution to follow the pulse.
Okay,
All you can do. Yeah.
so if you go into a religious institution, they're not gonna refuse to follow the pulse though, are they? Because isn't that supposed to be the law?
I've seen both happen, unfortunately. I've seen both happen. It just depends on who they are. Yeah, there's a lot of laws right now that they're supposed to follow, but they don't.
Do you have a list of those
Yeah.
hospitals that you could share with us?
Well, I mean, we all know who they are, but it's a matter of
I don't know who they are, so.
but any of the Catholic hospitals right now, but you may go there and they may follow it, and then the next time it depends on who's on duty that day, and what you need and don't need. That's what I'm saying. So I think having written on there that this is what you want, and that's why I also think going on, if you're at a point in your care, going on hospice earlier, don't wait till you're actively dying, even if you're just not getting curative care, because that gives you somebody else to call if there's something happening and you need care too. Because often what happens is, we're at home, and then something happens, and then we get taken to the emergency room. But it's rare. We all have contacts with doctors, like you say. How often are we unconscious and not able to speak for ourselves? And that's why having the documentation, and I have people hang it on the inside of the door where the EMTs could see it. So.
Oh, that's a good idea.
Yeah, I have a file. They advised me to have a
Yeah.
file with all the documents, because if you need, they need to call 911. For me, 911, I know what happened with my husband when he died. They choose the hospital. Remember, I said, where are you going? I am near Sherman Oaks. No, we are going to Providence.
Yeah.
Providence is San Joseph. San Joseph is Catholic.
Right.
And and you are not going to Shermanox, to Encino. They don't tell. When my husband, they brought my husband and said, tell me, we don't tell you.
Yeah, well, sometimes they don't know, the ambulance, sometimes where they're going, what's open, sometimes they can be diverting patients away from certain ERs, depending on how busy they are also, so.
Yeah, I was during the COVID. He didn't die the COVID. He died for malpractice of an Catholic hospital and never was documented. And they wait 1 week to have the death certificate. And I asked several people and say, yes, they call the legal department and they clean all the files and never know how he died. And he had no COVID. And for instance, I have experience sometimes the paramedics, they don't care, and also they don't want to speak with you. They take the person and they forget the other. More in my case, I am a homosexual, married with an homosexual. They refuse to speak with me.
Yeah, no, I understand. And COVID was, we learned so much from COVID, and a lot of things have changed. I heard a couple of great presentations at a conference from COVID, ER doctors. And unfortunately, we had to have a pandemic like that for ER doctors to realize that we need to start talking about palliative care and death right away. They never had to. Their job was to, get them stable and out of the ER and move them out. Well, now all through COVID, they were having to focus on these patients and new patients that were, actively dying right away or weren't going to make it. And all of a sudden, ER docs were having to address death and dying and palliative care. And now what we're starting to see is a real effort to begin these conversations about death and dying in the ER right away, and not ignore it, talk about it, and be prepared. And we're actively training ER doctors about that now. It's very, very important that we do that. So
I want to ask a couple quick questions before we go. Apparently, a certain percentage of the people who qualify and are approved for the end-of-life option cocktail end up using it. Does that mean that people at large end up with cocktail left over that is not being used, or is that?
No, that's a very good question. So we usually what we do when you finished with the process and then the patient's qualified, we don't hand them a prescription or anything. What we do is we electronically send a prescription to the pharmacy, and then when the patient's ready to take it, then we would call up and then pay for it at that point. So we're not getting it filled until the patient is ready and wants it. A lot of times I think some of those numbers, I think we're going to see some of the numbers start to change, because in the beginning, patients some of them, I think, thought they were going to use it and they didn't, but they weren't, so that's what's happening. It's not like the medication is floating around. And actually, that's one of the questions that when the doctor is talking with the patient, we explain to them, about keeping the medication safe at home. If we do have it delivered to the patient's home, maybe the day before or something, where to keep it safely. The medication is good for 6 months. So usually we keep it at the pharmacy until the patient's ready for it. But if they change their mind, it can be kept, safely in the home, up and away. Remember, you've got huge bottles of morphine and all kinds of other drugs in the home anyway when patients are on hospice. So this was always a big discussion in Sacramento about end-of-life option meds, like, oh, these could kill someone. Well, yeah, but it's a powder then. It's a very bitter powder. So no one's gonna, take it without having a lot of great difficulty to get the powder down. But we have, bottles of morphine that are in the home that are just as deadly. And they've been out there for hospice patients forever. And you have another question? Did you have another question? I'm sorry.
I did, and I was not aware that Medicare actually covers hospice costs. And I was wondering if there's just a basic number of days or how that works, or what do you know?
No, but there's a 6 month process with the medication. So like I said, with the medication with hospice. So after 6 months, if the patient is still alive, they look at how they've declined, have they gotten sicker, have they lost weight? As long as they still meet the criteria, then they would be up for another 6 months. Sometimes it goes 6 months, 3 months, but those are what Medicare calls pay periods. But yes, Medicare covers everything. I'm sorry, my dogs, I don't know what's going on out there. But Medicare covers everything of hospice. It's pretty much a hospice controlled program, a lot of it in that respect. So yeah, they do cover all of it. And like I say, Medi-Cal will cover the End of Life Option Act in California because it's a California program.
Thank you.